now it's really my big pleasure to welcome our expert key opinion leaders from the Asian Pacific Association of the Study of Liver Disease, APASL. So we have Professor Tawesak Tanwandee, who is the president of APASL from Mahidol University, Thailand, and also a big pleasure, Professor Shiv Sarin, who is the chairman steering committee of APASL from Institute of Liver and Biliary Science in India. So a big welcome to both of you to the EASL Studio here from Geneva. So first of all, probably both of you, but we can start with Shiv. Really, I'd like to hear your impression of the first day of the digital ILC and what stood out for you most.
Well, thank you for the kind invitation to APASL. I bring greetings from all the steering committee members and our executives. The EASL this year is a different feeling. We all thought we'll be in London, but it's different. It gave us opportunity, and I saw yesterday you can have 6 channels, and it was a very educative experience. And I must say, without wasting or running around with a mug in your hand of coffee or a sandwich, you could switch rooms, and it was a great feeling. Actually, we converted at the Liver Institute here into a big studio where we put in like 40 chairs, and there were people who were coming and going. They were doing their intensive care work or their outpatients or procedures and could walk. So for us, it was a good feeling. Now, yesterday was very good, and I enjoyed the 2 talks very much. One was managing pregnancy, cirrhosis in pregnancy. It was very educative for me. And the session on itching by the last sessions were very interesting for me. I also enjoyed the presentations, oral presentations, especially the one on L-carnitine and the Korean study. So I think it was a good walkover. I also thought the NAFLD session was very good.
Okay, Shiv, thanks a lot, and we will talk about later in much more detail about some of these presentations you mentioned. So, Professor Tanwandee, could we get some feedback from your side?
Yeah, I think, among the threat of the COVID-19, I think this is the opportunity for us to, and people around the world to view, and engage with the digital platforms. And the good thing for the digital platform is that, especially for those who are the audience around the world, can access on demand basis. And then, for the physical meeting, you can enter just one room at a time. But for this digital platform, you can learn on demand whatever topic that you are interested in. That's got to be the advantage of digital platform. Congratulations on behalf of the APASL for this movement of the EASL to lead us for this kind of learning. Thank you.
Oh, yeah, so thank you so much for this very kind feedback. So Phil, hand over to you. Would you like to start the discussion on probably COVID-19?
Sure, thanks, Thomas. So, and again, welcome again to both of you to the studio. It's fair to say that COVID's had a huge impact on the delivery of services to patients with liver disease in the UK and also in Europe. So, I mean, to you, Professor Sarin, what's been the impact, for you in terms of the delivery of clinical services with response to COVID? How have you dealt with this?
Well, all of us are aware of the problems. The Asian Pacific set up a task force on the COVID, and the task force included 26 members from different countries. The first survey was done called APASL study, Asian Pacific COVID liver injury spectrum study, and APASL 1 was published a few weeks ago in the Hepatology International, and it showed that those patients who had cirrhosis or had chronic liver disease, and once they're infected, they had a higher mortality, especially if the bilirubin levels or levels in enzymes were high. Second was a very good study, the guidance study, which was written in different sections, and that was the APASL guidance. It was just a few days after the EASL published the first guidance, which was very educative for us. And the APASL guidance also told us that we need more data. Most of the data was just speculative. So APASL started the second study called APASL 2, in which we thought how let's say for example, giving albumin, are the people coming back once a week, or they are not able to come for albumin, or how the practice in HCC has changed. We are collecting data in the APASL 2 study, and I do hope some of you others can also join, associations can join. The practice of hepatology certainly has changed to telemedicine or telehealth. Most of our patients are now being looked at by teleconferencing. And transplant numbers had gone down for 3 months. Now they have come up again. We are doing acute liver failure, almost 1 or 2 a week. They are coming now. So the practice is bouncing back, but we have learned to survive and manage COVID, and it's going to stay. So like in our ICUs, we have a separate ICU of liver with the COVID. So there are about 12 cirrhosis patients, 4 intubated with COVID. So those residents, intensivists are now learning this. So I think it's a huge learning. The practice has changed, and we have, to me, the best thing is we are now more connected than ever in expressing our fears, our limitations, and learning from each other.
Well, thanks, Shiv. So I think your point about telemedicine is very well made. What do you think will be the longer-term consequences in terms of telemedicine? You know, how many of these things do you think will retain, and what do you think the consequences of that will be on the doctor-patient interaction?
There was a beautiful paper in JHEP by Sumit Asrani, and they outlined how the telemedicine in liver diseases will work out. I agree to the data. In my opinion, in long run, this is going to be better for managing patients who are far off and those who require less intensive care. But what I have learned is now number of patients coming to emergencies have nearly become 1.5 times more. So people neglect and they don't come on their scheduled appointments, and then they land up into the emergency. So I think it will be worthwhile if EASL and APASL together make a big study on the impact of telemedicine on liver health and liver patients. I think we'll have more justified answer than impressions.
Yeah.
So, Shiv, may I ask you, also with your long-standing position at APASL, do you think that this COVID pandemic will change also the way liver associations will work together in the future?
Well, that's a good thought. That's a very good thought. It never occurred to me. But yes, liver associations must break boundaries and must now probably strive to have a more unified approach than before. And it is possible. It is visibly possible, and I think it's need of the hour. Several conditions where we have different guidelines. For example, the alcohol. It's a global problem. For example, NAFLD is a global problem. Why can't we have a global approach? So I think associations, and Phil being there, you being there, I think you could take the lead. And I think it's possible, and we should.
Thank you very much.
So, I mean, Shiv, you alluded to the the burden of COVID on patients with liver cirrhosis. So one of the areas that's interesting is, do you think non-alcoholic fatty liver disease is an independent risk factor for an outcome, or do you think that relates more to the underlying metabolic risk factors of obesity and type 2 diabetes?
Well, I think it's the metabolic dysfunction which makes the liver more vulnerable, but none of us have biopsies. Now we have some biopsies which are postmortem, but that may be too late. So as we read from the data, and George Lau had one of the first letter to editor in JHEP, where he had shown that patients who have got fatty liver or NAFLD have nearly twice more liver injury. The injury remains higher. Our own APASL study also showed that those with fatty liver. Now this fatty liver could be alcohol or could be anything. So I think presence of fat certainly makes the things worse. The injuries remains longer, and probably virus also secretion continues for longer period of time.
Thanks, Shiv. I mean, I'm sure we'll learn more as we get more and more data coming through the various registries across the world. So I'll now hand over to you, Pierre Manuel. I think you're going to ask some questions about liver cirrhosis and some of the studies presented.
Thank you, Phil. So, Shiv, coming back to yesterday's presentation, according to you, what was the most fascinating presentation, the one with the highest clinical implication?
Well, I must admit I didn't attend all, so my choice will be limited to what I heard or saw. And that is a huge bias, so please excuse me for my limited attendance in the meeting. But yes, I would like to draw attention to 2 or 3 interesting and what limited knowledge I have in the field of portal hypertension. I would say one study which drew attention was from Korea. I think it was by Dr. Yoon on L-carnitine as a supplement for 6 months given to patients who have cirrhosis and overt encephalopathy. And in that, they found that there is going to be an improvement both in the muscle as well as in the encephalopathy area. So I think the study was interesting. L-carnitine, of course, has, as everyone knows, has the capability of carrying the fatty acids into mitochondria so that they can be oxidized well and the energy can be utilized. Of course, it also supports your muscles. However, that study has a few limitations. One of them, major one, was L-carnitine levels were not done. We don't know whether adequate protein intake was given and whether ammonia levels correlated with L-carnitine. So, having understood the limitation, I think L-carnitine, as we used to do for cramps, can also be given for encephalopathy. It was something interesting which is translatable. Another abstract which I thought was interesting was pre and post tips, change in gut microbiome. I thought that was interesting, although it was written more poetic than scientific. Poetic in the sense they use the words like harmful bacteria or harmless or good bacteria, and I thought all bacteria are good. It is the host which doesn't accept them. So harmful versus harmless is not a great idea, but it did show that portal decompression, especially those who have no encephalopathy, have different bacteria. And whether it is the cause or the effect, whether encephalopathy is a result of these bacteria persisting or not, and they have more of this Lectinospiraceae and others. So I think that was interesting, and this opens a new window of explorations for us of bacterial translocation, encephalopathy, and access to the portal blood, and manipulating it through many mechanisms. So I think the change in gut bacteria and their direct connectivity to lung, liver, brain is a new area, and I thought that was a good, interesting paper. There were many others. One of them also included the sensitivity of the adipose tissue vis-a-vis adiposopathy with NAFLD. I think that was a very interesting paper. But if you have questions on some of them, I have gone through some of the portal hypertension areas, and I can deal with them if you have.
Yes, I would like, Shiv, to ask you questions. On the first one, L-carnitine, according to you, what is the the place for L-carnitine in the management of patients with hepatic encephalopathy now, based on the results you saw yesterday?
Well, I was a bit surprised that just a 2-gram supplement, just 2 gram, can make such a huge difference that your encephalopathy improves and your muscles improve. So I think higher dosages, longer studies, and a bigger group will be much better. But since it is a randomized trial, I have no reason not to accept their data. But I think it is useful in occasional patients with muscle cramps. Those who have near normal albumin, after albumin replenishment, if still the muscle cramps persist, I have occasional patients where it has improved, the cramps. I have not used it in HE, but after this study, I might like to try this out. But I have my reservations, as I said.
Okay. Another question now on microbiota. So there are many data now on microbiota in patients with liver disorders, including the one we saw yesterday. And do you think that these studies can be extrapolated from one country to another, or is there a specificity, a local or regional specificity of the microbiota?
Thank you. We are very happy. You know, the first ever report of the human study was from our group. We started FMT in 2013 and we standardized it for about a year and did the first pilot study in the alcohol, steroid ineligible patients with severe alcoholic liver disease. Those who had a DF above 90 or had sepsis or had, you know, no other transplant option. And compared to that, the non-FMT group, there was a survival advantage. And subsequently, we have done 3 more studies. Another one was on plenary in the ASLD, pentoxifylline versus FMT. And the third, which we have completed, is steroid eligible versus in steroid eligible FMT versus the steroids, and that is under review. I hope it gets some editorial support. In that, 55 patients had FMT and 57 were treated with steroids, and 90-day mortality was significantly better with FMT. The challenge is there is no score available. The Lille score is only based on steroid day 0 to day 7. There is no score. FMT is a slow process. It takes weeks. So we have to develop new scores, new methods of delta changes at day 28 and day 90. I don't know if it has ever been acceptable to people who are stuck to the Lille score. Having said that, there was an advantage in the reduction in the indices of liver disease. There was improvement in the MATE cells. There was improvement in the intestinal things. The bacterial profile is totally changed. And since we have completed 1 year, the bacterial change coexistence of what you can say good and bad was seen up to 1 year or so. The studies which have gone through and presented in EASL are the ones which included NAFLD patients or patients who have got addiction to alcohol. And that study, by giving enema, you are able to reduce the addiction in alcoholics, AUD, was very interesting. I would say anybody who gets an enema might actually leave alcohol, but it was a good study. And that was just for the sake of fun, I don't mind my saying. And the other study where patients with NASH compared to placebo got FMT also is interesting. So what your question means, can we transpose these studies to different countries? Well, I think with caution, with extra cynicism to yourself and every single data, I think it is worthwhile to try this, identify good donors. We normally use donors which are HLA matched or are relatives so that their HLA-A2 is compatible with the recipient. We think that the donor transplantation of feces is as if it's a liver transplant. With that background and vision, I think it's the first step and we have a long way to go.
Okay, thank you. I agree. We had a very nice session and talks yesterday. One last question, Shiv. More generally, what do you see as the main problem at the moment in the management of hepatic encephalopathy?
It's a very good question, and every day we have an intensive care unit with about 40 odd patients, and every night when you have 8 or 10 new admissions, the residents would report the patient has come with HE, but we do not know is it HE. It is encephalopathy, and one has to differentiate whether it is diuretic related or it is electrolytes or it is something. So in my opinion, majority of patients, we do not know the cause of encephalopathy. It is not definitely ammonia in all the patients. So for me, correlation, subclassification of overt encephalopathy into etiology or causative mechanism based is the first thing. Second, there is very limited data on neurohepatology. There is very limited thought process of what happens to the brain or different nerves in patients who have got HE. So I think we need a concerted effort on developing the field of neurology in liver disease. I think it's a huge challenge, and we are not even in the nursery.
Thank you very much. I now hand over to you, Thomas, to ask questions about viral hepatitis.
Yeah. Thanks, Pierre. Thanks, Shiv. So, Professor Tanwandee, yesterday we had a session on viral hepatitis C, and it was mainly on the long-term management. I think it has become quite clear that curing hepatitis C is, if it can be afforded, not anymore a big issue, but what to do with all these patients that have been now cured, how to follow them. So what was your take-home message from this session to start with? Can you give an overview?
Thank you, Tom. I think this is a big issue. Actually, life after the cures of Hep C still have some risk of the decompensation and development of hepatocellular carcinoma. And nowadays, with the availabilities of the DAA, especially in Asia Pacific countries where we have the generic one, so many people can access to the treatment. But still, even after the cures of Hep C, there's still some risk remain for the liver disease. And we all know that after the treatment, especially in the patient with advanced fibrosis or cirrhosis, we still have risk of decompensation or hepatocellular carcinoma. Even the portal pressure decreases after the treatment, and the risk of HCC decreases. But the problem though, how can we select or separate those with the risk factors or the risk of decompensation or development of HCC from those without the risk factor? So this could be a very important issue, especially in the public health manner, in order to make it more cost effective. And yesterday, during the digital
Sorry, may I briefly interrupt? Professor Tanwandee, I fully agree. So you're just going to mention the studies from yesterday. So I would like to specifically ask you, because there were two of them I found interesting. The one was a prospective trial coming from Egypt, and the one was a large, let's say, hepatitis cohort from France. And they tried to figure out what are the predictors of, let's say, liver outcomes after cure. So how do you interpret these data?
So for, most of the presentation look at the risk of HCC after the cures of hepatitis C. So for the data from, I think most of the data quite similar, but we look at the different parameters on the age, sex, and all of those things are quite similar, but still we need to have some similar conclusion in order to make it more beneficial. But both of the study also look at the the pre-treatment parameters of the hepatitis C, in that includes sex, age, and everything. That was quite simple for follow. But still, I think we need to validate this data. Even they have some internal validation, but still, I think we need more data in order to make all of these two models more useful.
Yeah, Professor Tanwandee, that's great. So do you have any recommendation in your region, in the APASL region, on how to follow and whether you should use any of these tests? For instance, in the EASL guideline that will be updated soon, so far it's written that those with advanced fibrosis F3, F4 should be followed lifelong. But quite often we do not have the exact amount of fibrosis, especially to diagnose F3 is not so easy. So what are you doing? What are the recommendations in your region?
We follow this. I think the guideline, the APASL guideline, is quite similar to the EASL guideline for us. Following the patient with advanced fibrosis. But still, the problem though is going to be the definitions of the cirrhosis. Is going to be quite simple, but advanced fibrosis F3 going to be quite difficult to classify without FibroScan or without liver biopsy. So, and I think the most important thing for us is to perform ultrasound twice a year in every patient. That's going to be very it's going to be burden for the resources. So we still recommend follow-up ultrasound with our LP every 6 months. But practically, this could be the issue for many countries.
Yeah. Can we safely discharge some of our patients? Let's say you mentioned these risk factors. So if it's a relatively young female, for instance, and from all the clinical judgment, there's no cirrhosis. So do you think there's any follow-up needed? Or is it important how the ALT levels are after the treatment?
I think we can safely discharge those patients, especially for those with recent infections, for those who know known duration of infections, according to the study from France. For those with non-significant fibrosis, whatever by any kinds of parameters, radiography or FIB4 or any definition, for those without underlying disease, especially diabetes, for those with non-genotype 3, so those can be discharged without long-term follow-up. But in between, some patients still have some parameters to differentiate whether one should be followed.
Yeah, you mentioned that the parameters you to calculate the risk of HCC were quite similar in the prospective Egyptian and the France study. And for me, it was surprising that in both studies it turned out that alpha-fetoprotein was a predictor. And alpha-fetoprotein is quite a lot in question whether it's a useful marker for the HCC prediction. So this is one prospective and a very large retrospective study. So do you see that this will also change the role of AFP for, let's say, cancer risk screening and to define certain risk groups? And are you using it?
Yes, this is interesting. Even the cutoff of both studies was not the same, but I think it was interesting. In both studies, they look at the baseline alpha-fetoprotein before the treatment. And previously, we incorporate alpha-fetoprotein for the screening. Actually, in the APASL guideline, we still combine alpha-fetoprotein with ultrasound every 6 months. So I think we need to look back and look at the role of the tumor marker in terms of part of the identification of the risk for the patient who are going to have HCC.
Yeah. There was one study from Austria looking at liver stiffness and other parameters to predict significant portal hypertension. And I was surprised that some of these patients had, even after treatment, a liver stiffness of 25 kilopascal or so. So in my personal view, it's really changed. We do not see any more patients we do treat now with such an advanced disease when starting treatment. So do you think this will also change our follow-up management, and how do you see it in your country? Do you see still patients coming with, let's say, significant fibrosis, cirrhosis, a high liver stiffness coming to treatment, or are now more the early stages?
So actually, it's still common in Asia-Pacific countries because usually the exposure to the hepatitis C is going to be several decades ago. So most of the patients have significant fibrosis, even cirrhosis. We can have fibroscan more than 20 quite easily. So my surprise is, that was the study from Austria. So yeah, I agree that it's going to be very uncommon in the Western country, but in Asia-Pacific country, I think this is going to be quite common. And however, the problem though is the fibroscan is not available everywhere, especially in developing countries, because it's quite expensive. So that's going to be another problem or issue for follow-up of the patient after the cures of Hep C in developing countries.
Thank you very much. So there was only one presentation yesterday on treatment, and this was on the unhappy few of those people who are suffering a relapse after quite effective treatment. So there was, and it was really a big effort to collect data from all around the world of patients who failed or suffered a relapse after triple treatment or after the GP glyceprevir piperacillin treatment. So what is your take from this study? Do we need this resistant testing that was done here, or what can we learn from this study?
So actually, this is interesting that that they try to collect all of the people that fail to respond to either GP or triple therapy, but still, I think in general, this is just informative for us, but in general, it's going to be quite difficult, especially in Asia-Pacific country, to look at those kinds of mutation or drug resistance in hepatitis C region, especially when we do not have GP or triple software works available in our region. In Asia-Pacific country, GP or software works only available in some like Japan, Hong Kong, Singapore, Australia, New Zealand, and Taiwan. But we don't have all of those two compounds available outside of those countries.
Okay, so there's no recommendation so far from APASL what to do with those failing triple therapy or the GP treatment? As a rescue treatment?
At the rescue. So this could be very important because at this time we don't have any recommendation for those who fail for all those two regimens.
Okay, so thank you so much for this wonderful discussion. So Phil.
Yeah, Shiv, I've got a question for you really in relation to the monitoring of patients with non-alcoholic fatty liver disease. So yesterday we had a studio session looking at or reviewing the non-invasive biomarkers. So I'd like to understand from your perspective, what do you see going forward we'll be using to monitor disease progression in patients with NAFLD, and how do we identify those patients that might be appropriate recipients of treatments as and when they're approved?
That's a very difficult question, and what I would say maybe philosophical. As Arun and Jacob and the group have put up the terminology as NAFLD, or metabolic dysfunction associated fatty liver disease. It automatically includes people who have got diabetes, it includes people who have got obesity. It's only the lean ones where we have to find out. So diabetics have to be screened, obese have to be screened, that is clear. Now remains those who are lean and have a F2 plus fibrosis. We published about 3 years ago a series of 1,000 liver biopsies, of which about 400 were lean NASH. And I would like to say, using the Asian cutoff of 23 BMI, there was no difference in their fibrosis between lean versus above 25, so-called obese. So to me, it is not clear whom to follow, whom not to follow when it is a lean or normal weight, whether it is metabolically healthy or a healthy person. I'm clear about diabetics, I'm clear about obese, but for lean, I would use a few biomarkers. And if the person is above F2 fibrosis, I would certainly follow every 6 months or so. If his liver stiffness is increasing, no question, he has to go on to therapy. If his liver stiffness is decreasing with normal enzymes, I would put on hold for new interventions. So F2 increasing, lean certainly would need an intervention, and I think we need to have focused therapy for them, whether it is GLP-1, whether it is your second generation FXR agonist or combinations, or it is sarclitazole. We need therapies.
Okay, that's really helpful. Thank you very much, Shiv. So I'll hand over to you, Thomas, to finish up.
Yeah, so this, we would like now to close this live studio session. So thank you both, Professor Shiv, Sarin, Professor Tawesak, Tanwandee, really for joining us. It was a great pleasure talking to you. It was great to have you with us. And I would now... Yes, please.
Just want to give our prayers on behalf of APASL to all the good people, and especially to Roger, who has been a mentor. Those days there was no Asia, there was no Europe, there was no America. It was Roger, and I think we all want to pay our tribute. We did it in our own way, but one more time, my president and myself and the APASL would like to pay tribute, and we'd like it to be recorded. One of the legends in hepatology, Roger Williams. Thank you.
Yeah. So we fully agree, and thank you very much for this very important comment. Thanks, Shiv.
Thank you.
So we'll say goodbye. See you hopefully later during one of these sessions.
And see you.
Yeah, bye-bye.
Bye now.